Good morning, everyone. Today we will learn a very important topic of OBS and gynae, which is stages of labor. So, there are four stages of labor. The first stage of labor is called cervical stage, which start from the true labor pain from the full dilatation of the cervix, that is 10 centimeter. And the second stage of labor is called expulsion of the fetus, which start from the full dilatation of the cervix to expulsion of the fetus. And the third stage is called expulsion of the placenta, which is the third stage, in which start from the expulsion of fetus to expulsion of placenta. And the last and the fourth stage of labor is observation stage. So one by one we will all discuss about the all stages in details and learn how the labor works. The first stage of labor is the initial and the longest phase of the childbirth, starting with the onset of regular painful uterine contraction that causes the cervix to soften, thin, that is effacement, and dilate from 0 cm to full 10 cm. First stage of labor is also called cervical stage of labor. It starts with good uterine contractions and it ends after full dilatation of cervix up to 10 centimeter. Time duration for a multigravida is 6 hours and for a primiparous is up to 10 to 12 hours. So the phases of first stage of labor is divided into three phases. First latent phase, second one is active phase, and third the last one is transition phase. So in the latent phase, it is the initial and typically the longest phase of labor. The cervix dilates up to 0 to 6 centimeters. In active phase, this phase is marked by a faster rate of cervical changes and more intense physical work. The cervix dilates from 6 cm to 8 cm. And the last one is transition phase. This is the shortest but most intense phase, serving as the bridge to the pushing stage. In this phase, the cervix dilates up to 10 to 8 to 10 centimeters, that is full dilatation of the cervix. So in the latent phase, the cervix dilate up to 0 to 3 centimeter and there is an irregular contraction and a cervical effacement almost complete. In the active phase, the cervix dilate up to 4 to 7 centimeter and the contraction is 5 to 10 minutes apart and the cervical effacement is complete. And last one is the transitional phase in which cervix dilates up to 8 to 10 centimeter and contraction is up to 1 to 2 minutes apart and lasting up to 60 to 90 seconds.
So now come to the second stage of labor. In second stage of labor starts with full dilation of cervix and ends with the expulsion of fetus from the birth canal.
Now discuss duration of second stage of labor. In primigravida, birth is usually completed within 3 hours, whereas in multigravida, birth is usually completed within 2 hours.
So now we talk about the phases of second stage of labor. In second stage of labor, there are two phases. First is propulsive phase and second is expulsive phase. In propulsive phase, this starts from full dilation up to the descent of the presenting part of the pelvic floor. And in expulsive phase, it is characterized by maternal bearing down efforts and ends with the delivery of the fetus. Now, I talk about the cardinal movements, which is also called principal movements. So, there are total 7 cardinal movements. First is engagement. In engagement takes place when the fetal head enters the pelvic brim. In primigravida, it occurs few weeks prior to the expected date of delivery, but in multipara, it may take place until labor actually begins. So second is descent. Descent takes place with increased flexion. It is a continuous process until fetus is expelled from the birth canal. So third is flexion. Flexion is essential to further descent. It occurs throughout labor, resulting in smaller presenting diameter, which negotiates the pelvis more easily. Flexion is achieved either due to resistance offered by undilated cervix or the muscles of the pelvic floor. So, what happens in flexion, that the baby bends its head forward, like chin touches the chest. It happens due to pressure from uterus contraction and resistance from the cervix and pelvic floor. Now, fourth is internal rotation of the head. So, when the occiput touches the iliopubic eminence and sinciput points towards the opposite sacroiliac joint, the occiput moves 1/8 of the circle anteriorly and comes under the symphysis pubis. So, fifth is crowning. So, crowning happens after the internal rotation of the head. Further descent occurs until the subocciput lies under the pubic arc. At this point, maximum diameter of the fetal head stretches the vulva outlet and the head cannot recede back even after the contraction is over. This is called crowning of the head. So, sixth is extension of the head. In this step, the sinciput face and the chin sweeps the perineum and the head is borne by the movement of extension. So, in this, after the crowning, the baby head starts coming out. The head bends backward and moves upward. First the forehead, then the face, then the chin comes out. Baby heads come out by bending. So, seventh is restitution. It is a visible passive movement of the head due to untwisting of the neck that occurs during internal rotation of the head. In this step, occiput moves 1/8 of the circle towards the side from which it is started. So, in restitution, head returns to its normal position. After the head comes out, it slightly turns back to its original position. This happens because of neck untwist. Like in simple words, baby head turns back to its normal after coming out. So, 8th point is internal rotation of the shoulder. So, anterior shoulder moves 1/8 of the circle anteriorly and comes under the symphysis pubis. At this point, fetal shoulders are in the anterior posterior diameter of the pelvic outlet. So, an internal rotation of the shoulder happens inside the mother and baby shoulders turn to come in the correct position. The front shoulder moves under the pubic bone. Like baby shoulder turn inside to come out easily. So, ninth is external rotation of the head. At the same time, when the shoulder moves internally, the head also turns 1/8 of the circle externally in the same direction as restitution. It means it outward turning of the fetal head after delivery of the head due to rotation of the shoulder. So 10th is birth of shoulders and trunk by lateral flexion. With further descent, anterior shoulder escape below the symphysis pubis first. By the movement of lateral flexion of the spine, the posterior shoulder sweeps over the perineum. The trunk is borne by the lateral flexion.
Hope so you have understand second stage of labor. Now moves to third stage of labor.
Now we are going to discuss the active management of third stage of labor, AMTSL.
The principles of AMTSL: first is follow management guidelines strictly. Second is excite powerful uterine contraction within 1 minute of delivery. Third is prevent complication like PPH, retained placenta, shock.
Now we discuss advantages and disadvantages of AMTSL. Advantages: minimize blood loss, shorten duration of third stage of labor, reduce maternal anemia, decreases maternal mortality. Disadvantages: increases risk of retained placenta not followed in multiple pregnancies, as can cause danger to unborn fetus. Then side effects of uterotonic like oxytocin, misoprostol.
Now discuss about the types of management. First is expectant management, which is natural method where placenta delivered without active intervention. Second is AMTSL, which is mostly preferred. Active intervention are made to initiate placental delivery, involves oxytocin administration, 10 international unit IM or slow IV, control cord traction CCT, and fundus massage. Now discuss about the procedure. Step 1: administer 10 international unit oxytocin IM or IV or 0.2 mg methergine IM or IV within 1 minute of delivery of baby. Step 2: if not delivered spontaneously, follow assisted placental delivery by CCT. Step 3: after delivery of placenta, thorough placental examination is done.
So this is the flowchart where you can get complete information about AMTSL. You can go through once if you want in detailed information.
Now discuss about the fundal pressure. Firstly, uterus is rubbed gently in circular motion with finger pads to make it hard, globular and contracted. If uterus is soft and flabby, fundal pressure cannot be applied. Pressure is given with 4 fingers above the fundus and in front apply pressure with thumb. It is done to ease retained clots of placenta inside uterus. Control cord traction, modified Brandt Andrews method. Palmar surface of finger placed above symphysis pubis. Body of uterus pushed upward and backward towards umbilicus. With right hand steady tension given downward and backward. Hold clamp until whole placenta comes out.
Now methods of placental separation. First is Schultz method and second is Matthews-Duncan method.
Now we will discuss about the placental examination. After delivery of placenta, it is placed on a tray washed in running tap water to remove blood and blood clots. Maternal surface, which is chorion, is inspected first for its completeness and anomalies. Normally cotyledons are present in closed approximation. Any gap indicates missing cotyledon. Amnion and chorion are to be examined for its completeness and presence of abnormal vessels. Cut end of cord is inspected for number of vessels, ideally 2 umbilical arteries and 1 umbilical vein.
Now we are going to discuss about examination of placenta. On maternal surface, that is the flaccid site, first we check completeness. Let the placenta flat and piece the 15 to 20 cotyledons.
Abnormalities. Inspect for areas of infarction, pale necrotic tissue, calcification.
On fetal surface and membranes, which is shiny side, membrane integrity. Left the placenta by the umbilical cord so the membranes hang down. Inspect both the amnion, inner and smooth layer, and the chorion, which is outer thicker layer, for completeness.
Now examine umbilical cord. Examine the cut end of the cord to confirm the presence of 3 vessels, 2 small arteries and 1 large vein. And check for the insertion site. Note where the cord attached to the placenta.
Now discuss about the general characteristics. Weight and the size. A typical term placenta weighs up to 500 gram, which is roughly 1/6 of the baby's weight. Odor. Note any foul smell, which is a strong clinical indicator of an intrauterine infection like chorioamnionitis.
Now we are going to discuss the fourth stage of labor, which is also known as immediate postpartum period, that focus on critical recovery and monitoring for the mother. Definition and its duration. Definition begins immediately after the expulsion of the placenta. Duration typically lasts 1 to 2 hours after delivery. It is a high risk window where the body transitions from childbirth to recovery. Why is this stage critical? Because the mother is at the highest risk of complications, especially postpartum hemorrhage. Physiological adjustments. The mother's body undergoes massive hemodynamic changes. Uterine atony, the most common cause of severe bleeding if the uterus fails to contract. Its goal, early detection to prevent maternal mortality. Physiological changes. First is uterine changes. Become firm, hard, and globular, located at or slightly below the umbilicus. Function compresses blood vessels to stop bleeding. Then lochia rubra, bright red vaginal discharge. Moderate amount is normal. Heavy soaking is a warning sign. Vital signs. Pulse may decrease slightly. BP should remain stable. Tachycardia plus hypotension, it indicates internal bleeding. Perineal condition. Checking for episiotomy, tears, or hematoma. Assessment protocols. Vital signs monitoring schedule. Check every 15 minutes for 1 hour. Then check every 30 minutes for the next hour. Key areas to check. Fundus, height, position, and firmness should not be boggy. Bladder, a full bladder prevents uterine contraction. Then bleeding, observe pads for excessive flow or large clots. Management strategies. First is uterine massage, gentle massage to stimulate a soft uterus. Then medication, administration of oxytocin 10 international unit IM to maintain tone. Then bladder care, encouraging the mother to void or catheterization if needed. Then breastfeeding, early initiation helps release natural oxytocin for contraction. Nursing and emotional care. Nutrition, provide fluids, oral or IV, for hydration. Then hygiene, perineal cleaning and regular pad changes. Then comfort, provide warmth and reassurance to reduce anxiety. Then documentation, accurate recording of vitals and blood loss is mandatory. Danger signs. Excessive continuous bright red bleeding, soft or boggy uterus that doesn't firm up, signs of shock, pallor, cold and clammy skin, dizziness or fainting, severe deep perineal pain. Health education and conclusion. Health education. Teach the mother to report heavy bleeding or extreme dizziness. Conclusion. The fourth stage is short but life saving. Final thought, vigilant nursing care in these one